previously we discussed how to prevent arterial thrombosis. Now we will discuss how to prevent stroke. So for that, obviously we need to look at the coagulation pathway. So as actually all of us know that there are two kinds of coagulation pathways. One is intrinsic system and the other is the extrinsic system. Intrinsic system happens when there is a surface contact. So there is basically no injury anywhere, but because of the contact contact thing, this whole pathway starts. But the second pathway happens when there is a tissue damage and there is a release of tissue factor. So we know that the intrinsic pathway 12 gets converted to 11, 9, 8 and this way, and then we come to factor 2 and which leads to the formation of clot, and the extrinsic system involves factor 7 and it can then directly go to act on factor 2 and then lead to formation of the clot formation. So if we have to prevent these pathways, what do we need? So we need to look at some of the final common pathways. If we act on the final common pathway, then naturally the action can be high and can happen, but sometimes we can even act on the pathway before the final common pathway. So conversion of 2 to 2A is the final common pathway as we know, and then that leads to formation of fibrin, and so this is the final common pathway. Now we need to know how do different factors affect these different areas. So if we look at acetrom or warfarin, that we know this is anticoagulants that we commonly use. The two types of anticoagulants, one is NOACs, which is newer anticoagulants, and these are the older anticoagulants. So these basically if you look at their effect, they are potent antithrombotic agents. This is what they are useful for. So very strong effect on stroke risk reduction, but they also have some effect on the arterial thrombosis also. So they could even reduce the stent thrombosis also. They have weak effect on arterial thrombus also, and they have a low bleeding risk. We know that. And where do they act? They can act at factor 9 and prevent this from activating factor 8. So in this pathway they act here and they can prevent formation of further they can block this whole pathway. So what are these anticoagulants? So they are vitamin K antagonists. This is the vitamin K antagonist. They could be heparin, they can be direct thrombin inhibitors, and then can be factor 10A inhibitors. So these are all the classes of anticoagulants that we will talk of, and we will talk of where they are effective. So warfarin is obviously vitamin K antagonist, and vitamin K antagonists act at this level. But if you look at NOACs, then there are two types of NOACs. NOACs are novel oral anticoagulant agents, and heparin is of course IV agent. It is not an oral agent. Heparin or low molecular weight heparin, they are all IV agents, but other three are all oral agents. So if you look at NOACs, there are two types of NOACs. One which acts at factor 2, and that is dabigatran. So what dabigatran does, it prevents conversion of fibrinogen into fibrin, so directly. So this is dabigatran. The other NOACs are active on factor 10. So factor 10A antagonist, and they prevent formation of basically fibrinogen to fibrin. So this is where they act, and the types are rivaroxaban, apixaban and edoxaban. So these are the three NOACs that are effective at this level. So, factor 10A inhibitors and factor 2A inhibitor. Factor 10A inhibitor rivaroxaban, apixaban, edoxaban, and factor 2A inhibitor dabigatran. Factor 9 inhibitors are this is vitamin K antagonists, vitamin K antagonists, and then heparin actually acts at many levels. So, heparin can also act at 9, it can also act at 10, it can also act at 2. So, heparins can act at multiple levels. So, heparin and low molecular weight heparin. So, they are active at multiple levels, but these other factors are effective at different levels. So, now the question is, which one do you choose? When to use vitamin K antagonists, when to use direct thrombin inhibitor, factor 2A inhibitor, which is dabigatran, and when to use 10A inhibitor, and that is rivaroxaban and apixaban and endoxaban. So, that is the question in mind. So, looking at vitamin K antagonists, and there are two types that are available in India. One is warfarin, that is there, and the other one is acinocumarol, which trade name is acetrom. So, these two are available with us. Now, we have to understand that how do you measure the activity of vitamin K antagonists? PT-INR. So, there are two basically doses of vitamin K antagonists. One where you achieve a PT-INR of more than 2.5, and the other where you achieve a PT-INR of less than 2.5. So, between 2 to 2.5. So, between less than 2.5 and more than 2.5. Where do you use more than 2.5? In mechanical prosthetic valves. And which cases do you use less than 2.5 dose? When you require mild anticoagulation, for example, in atrial fibrillation. So, atrial fibrillation you may use a low dose anticoagulation, but when you have mechanical prosthetic valves, you would use a high dose of vitamin K antagonists. Now, as I already discussed with you, that they also possess a weak anti-ischemic or weak anti-arterial thrombosis activity also. So, sometimes in some cases where you need more potent anti-thrombotic activity, you could even use them along with other agents to decrease the risk of arterial thrombosis if it is a very high risk. The only problem is if you use high dose of vitamin K antagonist, then it has a high bleeding risk. Now, the second question is to use warfarin or to use acinocumarol, because both are available. I think the difference is number one, cost. This is a more costly drug compared to warfarin. So, if cost is a consideration, naturally you would choose less costly preparation warfarin. But when cost does not matter, then how is the comparison? Basically, it has got a shorter half life, which means that if you stop, suppose somebody has to go for bypass surgery, suppose somebody has to go for any surgery where you need to stop the oral anticoagulation. So, if you use this drug, then maybe the duration of a stoppage will be less. Obviously, more rapid onset of action also. So, when you need more rapid onset of action, you may use shorter duration, but can cause GI disturbances, oral ulcerations and dermatitis. And these are the doses. Basically, you have to fine tune the doses according to PT-INR. So, the thing is that it is quicker acting and has got shorter duration of action. So, when you suspect somebody will go for surgery, you can stop acetrom for a shorter time and then you can send for surgery. With warfarin, you require a longer time, but it has got some GI disturbances and some other oral and dermatitis problems. Now, coming to NOACs, where do we use NOACs? NOACs are slightly more potent for stroke reduction compared to low dose vitamin K antagonists. So, if you compare NOACs with low dose oral anticoagulants, then NOACs are more effective and same or less bleeding risk. So, the only reason you would use a low dose vitamin K antagonist is when the cost is a consideration. Or there are some other problems with NOACs, I will come to that, or when there is kidney failure, patient requires dialysis, then NOACs are not safe. There you would prefer a low dose vitamin K antagonist. So, where do you use this low dose vitamin K antagonist? Broadly in AF patients. So, in a AF patient, if the patient has chronic kidney disease requiring dialysis or very chronic kidney disease, you would use vitamin K antagonist, or where cost is a consideration, you might use vitamin K antagonist. But where cost is not a consideration, you would always prefer a NOAC over a low dose vitamin K antagonist. Why? Because it is more effective with same or less bleeding risk. So, I think this is the important. But when you require a high anticoagulation, then NOACs are not as effective as high dose vitamin K antagonist. And what is that situation? Where you use a high dose of stroke prevention or high dose of anticoagulation when mechanical prosthetic valve. So, mechanical prosthetic valve is one condition. So, in that condition naturally you will not use NOAC at all. So, if somebody is using for prosthetic mitral valve, somebody is using NOAC, so that is not acceptable, it is criminal, because here you have to use high dose of vitamin K antagonist achieving a INR of more than 2.5. But compared to as I said, low dose vitamin K antagonist, they have less bleeding risk and they are also slightly less anti-ischemic. So, where ischemia is also consideration, you would among them maybe prefer vitamin K antagonist, but then also think that combination of 2 or 3 drugs will also cause more bleeding. So, NOACs will cause less bleeding. So, that is also a point, although more potent anti-ischemic. Here is the comparison with low dose vitamin K antagonists, and as you might have noticed that it has got more efficacy with less bleeding risk. So, this is that particular meta-analysis which shows you that it has got more efficacy with less bleeding risk compared to low dose vitamin K antagonists. We are not talking of high dose. High dose has vitamin K as more potent, but also much more bleeding risk also. So, now coming to real world situation, now let us consider what to use when. So, when can you use NOACs and when you do not use NOACs. So, mechanical prosthetic valve, you do not use NOAC. Why? Because you require more anticoagulation, more stroke prevention. Therefore, if you use NOAC, then it will cause stroke risk, it will not significantly decrease. So, because you require more anticoagulation, you will use a high dose vitamin K antagonist here. Likewise, in severe mitral stenosis with AF, also the stroke risk is very high, because with mitral stenosis there is also tendency of clot forming in left, because LA will get dilated. So, more chance of LA appendage also gets dilated. So, more chance of clot formation in LA appendage, also LA. So, here the in especially mitral stenosis risk of LA clot is high, and therefore, you use more potent anticoagulation, and therefore, you will not use a NOAC in moderate to severe mitral stenosis case with AF, because there it will have more stroke risk. But what about other valve diseases and mild diseases? Then you can use NOAC here, because it will have less bleeding risk and you do not require that much efficacious anticoagulation. In severe aortic stenosis, there is limited data, but again there is no LA enlargement, that much LA enlargement in aortic stenosis. So, you could use any of them. Still, bioprosthetic valve, again if it is due to rheumatic mitral stenosis, the LA may already be large. So, there you would prefer using a vitamin K antagonist, but other kind of bioprosthetic valves you could use NOACs. So, you understand why in mitral stenosis, because mitral stenosis LA is large, LA appendage is also large. So, lot of area where clot can deposit, and then if clot deposits, then obviously it can get embolized also. So, you require more anticoagulation. That is why. Now, mitral valve repair, after 3 months, once you do the repair, then LA will probably shrink in size, and then you could use NOAC also. Likewise, in percutaneous aortic valve replacement, there is not much data there, but you would be using a dual antiplatelet therapy like angioplasty. So, whether you want to add a NOAC or not does not make much sense. Already you are using a dual antiplatelet therapy. In hypertrophic cardiomyopathy, again the problem is whenever there is LA enlargement, then you have to make sure that you are using more potent anticoagulation, or when there is a prosthetic valve, mechanical prosthetic valve. With bioprosthetic valve, unless it is a MS situation, other than that bioprosthetic valve also you can use NOAC. So, I think you are clear where to use NOACs and where not to use NOACs, because that is very important. Next, the second question is, how do you choose? Suppose you have a case of valvular, let us say valvular AF. So, how do you choose, or even non-valvular AF, how do you choose what anticoagulation to use? So, you do something which is called as Chad-Vask score, and if you do not know, I recommend that you read it. It is a score which determines the stroke risk. So, there are some clinical factors and there are some tests also. Based on that, you determine how much risk of a stroke is present. So, this is a score that you should know, Chad-Vask score. So, read about it. If Chad-Vask score is into 3 types, it could be 0, it could be 1, or it could be 2 and more. So, generally it is divided into these 3 categories. If Chad-Vask score is 0, Chad-Vask score 0 means very low risk of a stroke. So, obviously you do not require anything. So, nothing is required if Chad-Vask score is 0, or even if it is 1 in a female, then you may not do anything. But if Chad-Vask score is 1 or more, then you would require some kind of oral anticoagulation. How do you decide what oral anticoagulation to give? How do you decide? So, you can see if that person has more risk of bleeding. If the person has more risk of bleeding, then you would use a NOAC. So, because NOAC cause less bleeding, low dose oral vitamin K antagonist got higher bleeding. So, if the bleeding risk is high, and how do you measure the bleeding risk? There is another score known as Hess-Bled score. So, read about it also, maybe because they will require another class or something, but this is another score which any patient you suspect bleeding, you calculate the Hess-Bled score, and then you will know how much risk of bleeding is there. Any patient you suspect a stroke, you calculate the Chad-Vask score, and you will realize how much stroke risk is present. So, if Hess-Bled score is high, then you would definitely prefer a NOAC. But if there is a cost consideration, because vitamin K antagonists are cheaper, if there is a cost consideration, or if creatinine clearance is less than 30. So, the other situation is when there is a severe chronic kidney disease. In that case, you would use a vitamin K antagonist. So, 2 situations or 3 situations, 2 situations for using vitamin K antagonist in a patient with AF. Number 1 is cost, number 2 is chronic kidney disease. If chronic kidney disease is present with creatinine clearance less than 30, then you have to use a vitamin K antagonist. But other cases, if some anticoagulation is required, and when anticoagulation is required, if it is 1 or more, then you would use NOAC. But if bleeding risk is high, then again you have to use NOAC. Then the options are limited, right? Now, among the 2, there is always this question, which one to use among these 3 commonly available NOACs. 3 commonly available NOACs are dabigatran, apixaban and rivaroxaban. So, these 3 NOACs are available. So, among the 3, which one to use, you have to decide. So, how do you decide? You compare. So, if you compare the stroke risk, you find that pretty much all of them have same stroke risk reduction. Maybe you can think apixaban may be little better, but it is not statistically significant, as you might see, because it is not on one side, it is still overlapping, but maybe you might think that apixaban may be more effective in stroke reduction. But if you look at type of stroke, so you realize that if you are preventing or if you are suspecting hemorrhagic stroke, then dabigatran may be little bit better, although it is again not statistically significant, but it is maybe it is skewed towards the dabigatran. So, you might think of dabigatran between rivaroxaban, but with apixaban there is no such difference. Apixaban may be slightly better than even dabigatran. So, if you look at a hemorrhagic stroke or bleeding risk associated with these 3, then you see that the highest risk is with rivaroxaban, then dabigatran, and least risk with apixaban. So, clear? It is favoring apixaban even in hemorrhagic stroke, although not statistically significant, but if you have to choose, then you will choose something which is better. So, what you find is that practically all of them have equal stroke risk prevention, but remember rivaroxaban is more potent than apixaban, which is more potent than dabigatran. So, highest stroke reduction happens with rivaroxaban, but highest bleeding risk, especially hemorrhagic stroke, also happens with rivaroxaban. So, rivaroxaban is more effective, but also more bleeding risk, especially at the dose prescribed, and we will come to that, because there are 2 types of dose. One, the other thing about rivaroxaban which is not there in other NOACs is that rivaroxaban also has a significant anti-ischemic risk or anti-arterial stroke prevention also, which other NOACs do not have that much. So, if you want to use it in a situation where there is a lot of ischemic risk, where there is a risk of arterial thrombosis, then rivaroxaban has the best profile, others will not prevent. But remember that dose is very low. Normally rivaroxaban dose is what, 15 or 20, but for ischemia that risk is only that dose is only 5, and that too 2.5 BD. So, in some cases where there is lot of ischemic risk, so uncontrolled unstable angina, or if somebody has end stage heart disease still getting lot of angina and lot of ischemic risk, you have done most of the things, but patient continues to have symptoms. So, a type of stable coronary artery disease, but high risk stable coronary artery. So, there is a trial. What is the name of trial? Hello. High risk coronary artery disease, there is a trial of rivaroxaban, and that is in 2.5 milligram BD dose. So, we might come to that, but remember that. So, rivaroxaban is the only one which also reduces stroke risk, but also significantly can reduce the arterial risk also, arterial thrombosis risk also. Now, other than efficacy and bleeding risk, what are the other things that you need to know? Number one that you need to know is dabigatran. If you look, we know it is 2A inhibitor, others are 10 inhibitors, we know that. It is a prodrug. So, remember that dabigatran is a prodrug. So, although it is acting on the final pathway, but the same problem that was happening with clopidogrel, that clopidogrel was a prodrug, it required 2 conversions to get converted. So, same problem is having with dabigatran, although you would think that it is acting on 2A, so final common pathway, but it does not happen because it is a prodrug, and so it converts into active metabolite, and the bioavailability, that is why, is only 6%. So, that is important to know, that there could be a wide variation in response of dabigatran because of this poor bioavailability. Half life is for all practically same, around 12 hours. The other thing is that dabigatran is excreted by renal route. So, which means that if somebody has got a kidney disease, even mild kidney disease, then dabigatran will face problems, because 80% is excreted by kidney, others as you might see is only less than 50%. So, any patient of chronic kidney disease, dabigatran you have to be very cautious, and in moderate or severe kidney disease you have to, it is contraindicated. So, this part is clear. But liver wise it is okay. Liver wise problem is with this rivaroxaban and apixaban. So, if somebody has liver failure, then dabigatran becomes drug of choice, but you cannot use these two agents, rivaroxaban or apixaban. What are the side effects? Most intolerance is present with dabigatran, because I think it is a pro drug, it gets converted and all that, and that causes dyspepsia also, etc., and so on so forth. So, what about absorption? See that rivaroxaban gets absorbed with food, 39% more absorption if rivaroxaban is given. So, that is why it is mandatory to give rivaroxaban with meals. This is one drug, normally we avoid giving drugs, particularly PPIs we avoid giving with meals, but rivaroxaban is one drug which you would give with meals. So, this I think you have to remember, right. Next. So, now practically how do we choose? Practically we know that all of them have almost equal effect, but apixaban has got the least bleeding risk. So, wherever there is a chance of more bleeding, you would choose apixaban because equal efficacy. Rivaroxaban has the highest efficacy, but practically all are equal, but apixaban is the one that you would use, right. If there is a GI risk, then you would use rivaroxaban or apixaban. If there is hepatic disease, then I already discussed with you dabigatran has always to be ingested with food. The problem is, the third problem with NOACs, two problems, one was cost, right, other was kidney disease. Third problem with NOACs is that antidotes are not available. So, if the bleeding happens, then you are stuck, you have not much options, because with vitamin K antagonist you have an antidote. What is the antidote? No, vitamin K antagonist. Vitamin K is the antidote. Protamine is for heparin, but for NOACs there is no antidote. So, this is the problem. So, only thing is that some new antidote has come for dabigatran at least, but others you have to be sure that you have to give in doses that bleeding does not happen, because once bleeding happens, then you have to wait for half life for the bleeding to pass away, because you have no antidote. You can keep giving blood and then wait for 12 hours till the effect passes away. So, that is the problem with NOACs, because there is this is the third problem with NOACs, that most of them have no antidotes. The antidote of dabigatran is very, very expensive. It is available, but it is quite expensive. So, although it is available, it is expensive. So, this is the problem. This is the third problem with NOAC. I think how to start and important thing to remember is, if creatinine clearance is less than 30, then dabigatran is contraindicated for sure. Even more than 30 to 60, you have to be very cautious. So, this is I think something that you need to know. Otherwise, you can see that you can use it, and depending on the dose, if it is a moderate dysfunction, you can use a lower dose also, but a higher dose is 150 milligram BD. Now, coming to how do you manage, suppose the patient is on NOAC, or then patient has to go for surgery, and as we know there is no antidote available. So, how long do we wait? That is the question. Generally, if it is a minor surgery, you wait for 2 days, except if you are giving dabigatran in renal dysfunction. There you may have to wait for 3 days because of longer half life of dabigatran in renal dysfunction patients. So, if the creatinine clearance is between 30 to 50, then you might have to wait for 3 days, otherwise 2 days is okay for all the NOACs. And when do you start? 1 day after surgery. This is for minor surgery. For major surgery, you have to wait for 3 days. With dabigatran, with some renal dysfunction, you have to wait for 5 days. And when do you restart? After 2 days, you restart. So, wait for 3 days, start after 2 days. Minor surgery, wait for 2 days, start after 1 day. So, this is the normal thing, except if you are using dabigatran in some renal dysfunction, then you have to have a different timing. The other thing that comes to mind is I want to switch from, let us say, vitamin K antagonist to NOAC, from this to that, from this to that. How do you do that? So, if the patient is on vitamin K antagonist and you want to start NOAC, then you wait till INR is less than 2. Once INR is less than 2, you can start NOAC and you already stopped vitamin K antagonist. If you have to switch from heparin to NOAC, what do you do? After the dose, wait for 2 hours. After 2 hours of stopping unfractionated heparin, you can start NOAC. So, if somebody is on infusion, then you stop the infusion, wait for 2 hours and then start NOAC. If somebody is taking low molecular weight heparin, then what do? You wait for the time till next dose was due. So, suppose you are giving 6 hour low molecular weight heparin or 8 hour low molecular, so wait for 8 hours, and when the next dose was due, instead of that you give NOAC. From NOAC you want to switch to vitamin K antagonist. What you do is you just add vitamin K antagonist and keep monitoring INR. Once INR becomes more than 2, then you stop NOAC. So, you can give both of them for some time, overlap them for some time till INR becomes more than 2. From NOAC, if you want to give unfractionated heparin or low molecular weight heparin, what do? You wait for the next time of the dose. Once that time has come, instead of that dose, you give unfractionated heparin. And from one NOAC to other, obviously, when that half life is over, the next NOAC is due. Instead of that, you change and use whatever you want to use. So, if you want to change from rivaroxaban, let us say dabigatran. So, rivaroxaban you use once a day. So, next day you start dabigatran. But if from dabigatran you want to switch to rivaroxaban, because dabigatran you give 12 hours. So, after 12 hours you start rivaroxaban that way. So, whenever the next dose is due, you start the agent. When can you, are there situations where you use both of them simultaneously? So, one situation is when arterial thrombosis risk is very high. There you give dual antiplatelet and you might have to add even a NOAC, and we will discuss that, but that is one possibility. The other is when both risks are present. So, if there is a case undergoing angioplasty and also got a AF, so you require stroke risk reduction and you require arterial risk reduction. So, both the type of risks are high, then you may combine the two drugs. So, before combining, I think you have to understand what is the ischemic benefit, what is the thromboembolic or stroke benefit, and what is the bleeding risk. So, if you look at aspirin, very low arterial thrombosis reduction, also low stroke reduction, but very low bleeding risk. So, very good here, very low bleeding risk. So, this is bleeding benefit or low bleeding risk. So, that is why you could use aspirin. Among all of them, if you would notice, aspirin has the lowest bleeding risk, followed by NOAC, and then vitamin K antagonist, and highest risk with prasugrel, which we also discussed last time. So, highest risk with prasugrel, but lowest with aspirin and then NOAC. But if you look at thromboembolic benefit, the most benefit with NOAC versus low dose vitamin K antagonist. But if you use high dose vitamin K antagonist, then benefit of a stroke benefit will be even more. But I have only talked of low dose vitamin K antagonist. But others, they have mild benefit, as you might see, in stroke reduction, but not much. So, if you add them to any stroke reduction anticoagulant drug, they will also slightly reduce the stroke risk, but at the cost of much increased risk in bleeding. if you look at ischemic benefit, maximum benefit with prasugrel, as you might already know, then ticagrelor, then clopidogrel, but also good amount with vitamin K antagonist and at least one NOAC, that is rivaroxaban. Rivaroxaban also has got a good anti-ischemic benefit. So, principle of combination is to understand once you combine what happens. So, suppose you combine two drugs, aspirin with P2Y12 inhibitor like clopidogrel, ticagrelor, etc., then benefit will be there and bleeding risk is there. So, this is the standard thing. But suppose you want more anti-ischemic benefit, or because if the risk is higher. So, for example, if you are doing angioplasty in a MI patient and is not properly controlled, multiple more lesions are there, something like that, then what you can do? Then you can combine NOAC with, instead of aspirin, use NOAC, because you know NOAC has more anti-ischemic effect, and combine with P2Y12 inhibitor. The only thing you have to remember is that you use only clopidogrel, because if you use any other P2Y12 inhibitor, then bleeding risk will increase much. So, you use only clopidogrel. So, you can combine NOAC with clopidogrel. Also, what you can do is you can combine DAPT with low dose NOAC also. That is also another possibility which has got a good ischemic benefit as well as bleeding risk. But the highest bleeding risk is there when you use triple antiplatelet therapy. So, which means that you use dual antiplatelet full dose, and then you also use full dose anticoagulation. So, that will, the triple antiplatelet will have a very high risk. This is not actually DAPT, this is clopidogrel plus low dose NOAC. So, this is a mistake here, but this is clopidogrel with low dose NOAC, because combination of DAPT with low dose NOAC becomes triple antiplatelet therapy. Triple antiplatelet therapy, you see, has the highest bleeding risk, but it does not give any great ischemic benefit. So, you see, people think that if there is angioplasty and you has AF, maybe you use all the three drugs, you use clopidogrel, you use aspirin, and you can also add either long term heparin, or you can add vitamin K antagonist, but you see that there is no benefit in ischemic benefit. As a matter of fact, DAPT with low dose NOAC has more benefit than triple antiplatelet therapy, but bleeding risk is much higher. So, this is something which you never do. But as I said, you can use vitamin K antagonist with one P2Y12 inhibitor. And which one do you choose? P2Y12? Always clopidogrel, because if you use anything else, then bleeding risk will increase. So, either you can use vitamin K antagonist with clopidogrel, or you could use any NOAC, especially low dose NOAC with clopidogrel. So, this is the thing that you would be doing if you want more potent antiplatelet activity. But remember that if you combine the two, then the antiplatelet activity or anti-thrombotic activity increases, but bleeding risk also increases. So, I think the bottom line is that if you look, if you want to reduce the thrombotic risk, least prevention with DAPT. If you add triple antiplatelet, little better than DAPT, but better still is a combination of clopidogrel with vitamin K antagonist, or NOAC with either low dose clopidogrel, or even combination but low dose. So, this is the thing, and but full dose will have more bleeding risk, and the highest bleeding risk is there with you can see that combination full dose with triple antiplatelet therapy, that will have the highest bleeding risk. Now, if we think that if we have to use dual antiplatelet therapy and we have to combine some anticoagulation, so naturally we do not combine the full dose anticoagulation, because full dose anticoagulation will be triple antiplatelet therapy, will have very high bleeding risk. So, you have to combine low dose anticoagulation, number one. Obviously, at the time of PCI, you combine with unfractionated heparin or low molecular weight heparin, that we already do. So, we give a modified dose of heparin, control dose. So, it becomes a low dose with dual antiplatelet therapy. So, this is a combination that I was talking about, dual antiplatelet therapy, but low dose anticoagulation, either with heparin or low molecular weight heparin, which you can do in these two situations. But if you use another drug which is bivalvuloridine, because bivalvuloridine is not only potent anticoagulant, but it has also got some antithrombotic effects also, but it can cause more bleeding and its action is very short. So, generally it is used in where you cannot use heparin. And what is the situation? HIT? Heparin induced thrombocytopenia. So, what is a typical patient of heparin induced thrombocytopenia? How do you know that this person is having heparin induced thrombocytopenia? No. If you give heparin for some time and then you take for PCI and you give some more heparin, then there is a likelihood of developing heparin induced thrombocytopenia, and that heparin will not actually affect much, and rather it will cause a lot of bleeding. So, there you use bivalvuloridine. So, for heparin induced thrombocytopenia, the treatment is bivalvuloridine. Now, instead of heparin and bivalvuloridine, suppose you use fondaparinux, which is another drug available, then what happens? This is not as good anticoagulant as bivalvuloridine or low molecular weight heparin or this, because I am now talking of IV drugs, because oral we already considered, these are all IV drugs. So, sometimes you have to quickly get the anticoagulation effect. So, you cannot use oral drug because it will take 12 hours, 14 hours. So, you have to give IV drug. So, this is comparison of all the IV drugs. So, unfractionated heparin, low molecular weight, same efficacy, same antithrombotic efficacy and same bleeding risk. Bivalvuloridine, more potent antithrombotic activity, therefore, in angioplasty situations can be more helpful, but three problems. One problem is that it can cause more bleeding. Second problem is effect is short lasting. As soon as you stop bivalvuloridine, the effect will go away. Heparin effect will last for some time. So, you have to continue giving the drug. And third problem is that it is more costly. Bivalvuloridine is more costly than heparin. Heparin costs 1000 rupees. Bivalvuloridine may cost 10,000 rupees or something like that, or even more. So, this is the problem. So, the third thing that you could use is fondaparinux. Problem with fondaparinux is that it is not as effective as heparin. So, it can be used in any patient who is not undergoing PCI, because in PCI you require more potent drug. So, in a patient of acute coronary syndrome whom you think I am not going to do PCI for whatever reason, there you can give fondaparinux, but not in somebody who is going to go for PCI. So, this is the important thing. And then finally, the most potent drug of course is, as I said, GP2B3 antagonist. This is the most potent drug, but highest bleeding risk and also higher cost. It again costs different now, but different groups of 2B3 antagonists are present, and we can discuss some other time because they are no longer used that much, but have higher cost than heparin. Heparin is the cheapest. Now, this is special situation where both thrombotic risk or arterial thrombosis risk and stroke risk is present. So, a person who is undergoing PCI, so arterial thrombosis risk is high and has got AF also. So, AF undergoing PCI is a higher risk. What do you do? So, of course, you know, in any regular variety we use DAPT, but if AF is also present, then this thing, a dual combination, instead of aspirin you use vitamin K antagonist. So, as I said, vitamin K antagonist is more potent antithrombotic as well as anti-stroke agent compared to aspirin. Aspirin is weak in both places. So, you could use this, which is both anti-stroke as well as also good anti-platelet or anti-arterial thrombosis. So, this combination could be used. The other opportunity could be that you could use a low dose NOAC with dual antiplatelet therapy, the one I was discussing. Only thing you have to add low dose, because high dose with DAPT becomes triple antiplatelet therapy, which is very high risk of bleeding. So, you could use a low dose NOAC with dual antiplatelet therapy, and dual antiplatelet therapy with clopidogrel. Here you don't use prasugrel or ticagrelor because again the risk will increase. So once you are combining 3 drugs, you have to make sure that low bleeding risk you have to combine. So low bleeding risk, you combine low dose NOAC with dual antiplatelet therapy with clopidogrel. If you use ticagrelor or prasugrel, there will be a lot of bleeding, so you can't use. So this is out. But if there is really high risk of stent thrombosis for certain reason, then maybe you can combine ticagrelor and aspirin. But if there is just high bleeding risk, very high bleeding risk, the risk is so high that you cannot even use dual antiplatelet, then you can use a single agent, either ticagrelor or prasugrel. So I think this is clear. Practically these things are clear, isn't it? Now the second question is, as I said, these are for prevention of clot formation. But if the clot is already formed, then obviously you need to dissolve the clot. And the way to dissolve the clot is to give these agents. This is streptokinase, urokinase, RTPA and tenecteplase, TNK. So as you might see, the TNK is the best agent because it is most fibrin selective, which means wherever there is recent clot formation, it will dissolve that. So in MI you could use it. Others can cause bleeding anywhere where even there is not that recent clot, and that is a problem. So they can cause more hemorrhagic CVAs, etc. But tenecteplase will cause the least because it is most selective, and also you can give it in a bolus form. Just give a bolus and that is it. For streptokinase you have to give for 60 minutes, means 1 hour. So that is the problem. And best reperfusion achieved 70%. But now this can achieve only 70%. So best of thrombolytic therapy will achieve a reperfusion rate of only 70%. That is why angioplasty is always better in especially acute MI situation, because you can achieve 95% or 99% reperfusion. So it is always better than using any thrombolysis, unless it is in the golden hour, and I mean we will not go into that. But broadly, that is why it is criminal to not send acute MI patient for angioplasty. If you come across acute MI patient within window period, then they should be sent for angioplasty, especially if they are more than 1 to 2 hours old. Then it is definitely, angioplasty is definitely better than any thrombolysis. So I think this is perhaps my last slide, tips and tricks of using antithrombotics. So this is the rule number 1 I told you. Whenever you are combining P2 Y12 inhibitors with NOAC, a lower dose NOAC should be used. And whenever you are combining, also remember that P2 Y12 inhibitor should be clopidogrel and not ticagrelor. So whenever there is a combination, you use the simplest thing, low dose clopidogrel. This is the other thing I told you, rivaroxaban is the only NOAC which in low doses possesses anti-ischemic property also. But here remember, the dose is low, 2.5 milligram BD. At this low dose, it will not cause stroke prevention. So if you dose low dose of rivaroxaban 2.5 mg BD, it will not cause stroke prevention, but it will reduce the ischemic risk or arterial thrombosis risk. Now as I said, NOACs are associated with significantly lower intracranial bleeding, whether it is low dose VKA or high dose VKA. Newer P2 Y12 inhibitors like prasugrel, ticagrelor should not be combined with anticoagulants, whether it is NOAC or whether it is vitamin K antagonist. You should combine only clopidogrel. So I have seen many prescriptions, people are using acetrom or warfarin, and they are also writing prasugrel or ticagrelor. That should not be done. So that is criminal. Next. Now coming to thrombolytic, I already told you that if you have to use, then TNK is the best. Why? Most efficacious, bolus can be given, and there is less bleeding risk. Because why less bleeding? Because it acts only on the recently formed thrombus, the fibrin specific thrombus, so that it dissolves. So that is why it can be safer. This next. So I would conclude that for risk of arterial thrombosis, antiplatelets are more useful, But when venous thrombosis is a problem, then anticoagulants are more useful. And antiplatelets are aspirin, clopidogrel, ticagrelor and prasugrel in this increasing order of anti-ischemic efficacy. If a venous thrombosis is a problem, then of course anticoagulants are more useful. Aspirin is very weak anticoagulant, so maybe don't think of aspirin. Low dose vitamin K antagonist is the next potent anticoagulant, then NOACs, and then high dose vitamin K antagonist. So this is the order. Clopidogrel is safer but less anti-ischemic. So if you require more anti-ischemia and you are using only with aspirin, you could use either ticagrelor or prasugrel. NOACs have equivalent anti-stroke effects but less bleeding risk versus low dose vitamin K antagonist. Next. So I think this is it. And this is the book I wrote, Cath Lab Practicals. So once you come to interventional cardiology, then it might be useful to you. So I think, friends, thank you so much, and I think this concludes our discussion. Now any doubts, any questions you have, then I'll be very happy to answer.